Is Dr. Irshad. He is a cornea refractive surgeon at Malabar Medical College. Over to you.
Thank you, Dr. Shaji, for including me in this IC. Good morning. So I'm going to present about immersion biometry getting perfect results. So in this era, we are most of the surgeons in government hospitals or who does not have availability of any optical biometer. We constantly have to use an ultrasound biometer. So in ultrasound biometer, the most important thing is training your technical staff. So you have to spend a lot of time in this training and you have to modify this training accordingly about immersion technique, the spike pattern interpretation, the correlation of this measurement in myopic and hypermetropic patients, and check for the inter-eye differences. And there should be an ergonomically designed room for this immersion biometry, because patient has to lie down, technician has to do with that position, and at the same time technician has to see the monitor also. So a room and a well qualified technician is very important thing. Second one, you should have a technician who is constantly doing biometry for all patients. So if there's so many technicians and fellows or PGs, that's actually not good for this biometry. So how does this biometry works? Because it's a thin focused sound beam that reflect in the interface. Interface means area of different refractive index. So in contact scan, the main problem is the corneal compression. This corneal compression can lead to a different and AC depth in different scan that leads to a change in the axial length. That also can lead to corneal aberration and poor repeatability. So we always try to do immersion for all of our patients. So in this case, we are using a shell that is filled with distilled water or saline, and we look for the waves. So there should be a double-peaked echo on the cornea that's showing the anterior and posterior surface of the cornea. There can be the anterior wave echo from the anterior lens capsule, echo from the posterior lens capsule, and retinal waves. This retinal echo should be sharp 90° from the baseline. This is very important. And there should be a scleral spikes and then orbital fat. So how do we know? It's perpendicular to the visual axis. As we discussed, there should be all these 5 or 6 spikes. And if you see the fourth spike, it should be exactly 90° from the baseline. In the second picture, you can see the retinal spike is not perpendicular, and in that picture, you have to repeat the A scan. And whenever there is the two, you look on the lens spikes, there should be equal lens spikes from the anterior and posterior capsule. So if it is different, that means it is not well aligned. So there should be a 90° from the baseline, the retinal spikes, anterior and posterior lens spikes should be in similar length. If it is focused towards the optic nerve, there will be missing scleral spikes. So in this picture you can see after the retina, you can see only the orbital fat. There is no retinal spikes. So that means it is directed towards the optic nerve. So this gives a false value. And you have to optimize the gain. So what is gain? It is the amplification of the echoes on the display screen. If gain is very low, you get very small spikes. If it is very high, you lose resolution. So what is resolution? It is the, you have to use minimum gain that gives a good resolution. That means you can clearly identify the retinal and scleral spikes. In pseudophakics, you have to check for the IOLs, because the velocity in different IOL varies. You have to, if you are doing comparing the eye with a pseudophakic patient, you have to carefully select the type of IOL used in the calculation. So formula of choice, nowadays we use Barrett's online calculation for all patients. Ideally, in shorter axial length, you can use Hofer Q, and longer axial length, you can use SRKT. So, but it does not include the effective lens position because it is not including the AC depth and lens thickness. So in all patients, we use SCRS calculation, online calculation, either by a mobile or a laptop. You can just enter the value and you can enter the AC depth and lens thickness. That gives a better result in all patients. So by doing this, we have achieved more than 80% of the patients getting almost within 0.5 diopter value. So in nutshell, you should have a trained staff who is doing biometry in all patients, positioning of the patient, a well-aligned probe, appropriate gain, and a proper formula gives the best results. Thank you.
Thank you, Dr. Irshad.